Good afternoon everyone. Myself Dr. Kirti, Assistant Professor Physiotherapy Department. So today we'll discuss about hip and trunk deviations. So basically deviations at hip, like heel strike to foot flat, they could be hip excessive flexion, limited hip flexion or limited hip extension, which could be due to hip or knee contracture or weak soleus or quads, or we can say weak hip range of motion, loose max weakness or spastic. So from foot flat to mid stance, the internal rotation could be due to internal rotation spasticity and weak external rotators. External rotation could be due to excessive backward rotation of opposite pelvis, and abduction could be due to contraction of the gluteus medius and lateral trunk lean over ipsilateral side. So from foot flat to mid stance, the deviation could be adduction and spasticity of hip, and there could be adduction and pelvic drop on the opposite side, and during the swim phase there could be circumduction, and there could be the compensation for weak hip or for inability to shorten the lower extremity. So hip or knee flexion contracture, patient has flexed position of hip and knee during stance phase as shown, and will often see increased lumbar lordosis and reduced stride length. So it is also known as crouched gait as shown in this figure. And the deviations at trunk, like during the stance phase there could be the lateral trunk lean, which could be due to weak or paralyzed glute medius on stance phase, and backward trunk lean, which could be due to weak or bigluteus maximus during stance phase, and forward length trunk forward trunk lean, which could be due to weak quads, hip or knee contracture. So first we are having the hip abductor weakness. Normally the hip abductors stabilize the pelvis and limit the downward rotation in front leg. So during mid stance, pelvic can drop during swing in the swing leg, and there is visible lateral movement during stance leg. So it is known as uncompensated gluteus medius on Trendelenburg side, which is mild and moderate. And when weakness is more severe, hip pain is present. So the biomechanical compensation is to shift the center of mass toward the stance leg, and which appears as lateral shift, and bending of trunk over the stance phase leg. Fast walking may pose a problem. So if the hip abductors are weak, they may be unable to contract with a sufficient force to stabilize the pelvis. So pelvis will dip on the side of the foot which is off the ground, that is Trendelenburg side. So in order to reduce the demand on weak muscles, subject will employ the lateral trunk bending in both standing and walking. Hip abductor weakness could be caused by the disease or injury affecting the muscles. Hip extensor weakness, so usually there is a forward motion of the leg is slowed, and so with weakness the walking speed is slow to reduce the forward momentum. The trunk center of mass is moved relatively posterior by increasing the lumbar extension. So when weakness is bilateral or associated with limited hip extension, as is common in generalized myopathies, increase in lordosis is often typically present. So when weakness is isolated to gluteus maximus, there is backward thrust or throwing of the trunk at strike. Next we are having the hip flexion contracture. So normally hip joint normally moves from position of 20-30 degree of flexion at initial contact to 10 degree of extension terminal stance. So with the pathology it can cause limitation like of internal and extension. So when hip flexion contracture occurs, abnormalities are usually seen in the later half of the stance, and when extension range is lacking, the pelvis must flex forward. The most common strategy used by the patient is to increase the lumbar spine, that is extension means lordosis. And to reduce any tendency for hip to move into flexion, there is reduction in knee flexion, limb is maintained in the extended position. And lumbar spine extension compensate for hip flexion contracture. When hip flexion contracture is more than 15 degrees, so there is limited spine extension, or an alternative also strategy used by the patient is increased knee flexion with ankle dorsiflexion. So it is uncommon strategy because it could be fatiguing for the patient, can lead to arthritis. Thank you.